Well, hello. I'm Tiddu Manku from Windsor in England, and I'm going to be presenting to you a presentation talking about the interdisciplinary management of implants in the aesthetic zone. And we're going to really look at the current contemporary concepts for achieving predictability and success with this type of treatment protocols. Of course, what we have to understand is that really the keys to successful implant treatment is what we want to really focus on. And there are some keys. There are some key elements that help us to manage our implant cases effectively. Because from my perspective as a private practitioner, I want to try and produce outcomes for my patients which will stand the test of time. And so that when we create an implant restoration, that we know that the soft tissue surroundings, the end aesthetic outcome is going to be something that's going to be stable and be predictable and maintain health and stability over the number of years ahead. So it's not just about making an outcome which will last for the final photographs, but really something that can be there for the next 3, 5, 10 years. Of course, we understand that in our implant dentistry today, we have to work with multiple disciplines, and of course it is in this interdisciplinary fashion that we really manage most of our patients today, whether we're doing implants or any other aspect of aesthetic dentistry. And really we use these different modalities of treatment in order to best manage the form, the function, to understand and really manage the biology. And this is a critical importance today, that the biological aspects of the behavior of the tissues is something that we really understand well. And if we can really understand and anticipate the biological response to our treatments, we can optimize the outcomes of our treatments. Of course, we work with a high level of precision, and we have to achieve aesthetic outcomes which our patients are going to be happy with. The standard that we work to, of course, today is what we can achieve with natural teeth. And if we look at this slide here, we can see a 5-year follow-up of a few ceramic restorations on anterior maxillary teeth. And you can see that when we have a healthy foundation to work with, that we can achieve very nice outcomes with soft tissue that integrates very well with the restorations, and we're maintaining health. And we have restorations that mimic very closely the appearance of teeth. Of course, our goal with an implant restoration is to achieve the same sort of outcome. And the right central incisor here is a single tooth implant restoration, and we have to understand that this is really our goal, to achieve a good outcome with our soft tissue, to have something that mimics the correct soft tissue anatomy around a natural tooth, and a restoration that closely mimics the natural tooth. And so the key thing, I suppose, in implant dentistry today, particularly in terms of the aesthetics, is to have stable soft tissue aesthetics. And this is really the challenge for us, and this is the key that we need to focus on. Let's have a look at some of the basic foundations, because we have to understand that, of course, everything boils down to diagnosis and treatment planning. And when we're presented with a case like this, and you can see from the slides that this is a case that presented to us in 1994, some time ago, and we have to understand that the principles that we employ are going to stand the test of time. And this is really a key element. And of course, sometimes the cases that we treat are not very simple and straightforward, as we can see in this particular case here. And of course, if we're going to work with these types of cases, we need to have protocols and a systematic approach which allows us to work with our interdisciplinary aspects and to manage the dental tissues, to manage the periodontium, to manage the functional issues and the occlusion, and to manage aesthetics effectively. And we need to have a protocol for our treatment planning management, where we have a stage treatment plan protocol that allows us to control disease, establish a healthy foundation, as you can see in stage 1, to then modify that foundation to try and improve the outcomes and the baseline that we're starting with, to make it easier to get a better result. We provisionalize, we stabilize, and we have a working prototype of what we intend to achieve. And of course, what's very important is to be able to reevaluate our cases, particularly these complex cases, over time, because it may well be that we start treatment with one goal in mind or one plan in mind to remove some teeth or maybe to save some teeth, and as we go along we find that those teeth do respond better than expected to treatment and we're able to maintain them and incorporate them into our restoration, or perhaps the opposite is true. We find that they are perhaps not being stabilized as effectively as we wished, and we wish to remove them and place implants or have an alternative strategy. And of course that is very important that we do that as we go along with these cases until we reach our final stage of, or our stage 4, which is the stage of being able to place our final definitive restoration. And let's not forget, ladies and gentlemen, the importance of having a structured maintenance program so that we can maintain those cases over time. So if we go back to the case that we were looking at, we can see us going through stage 1 and stage 2, controlling disease, starting to work with the foundation to modify it, going through the various disciplines. In this case, we've carried out periodontal treatment, endodontic treatment, and basic restorative treatment. We've placed implants, we've placed, done bleaching, non-vital bleaching. We've now placed orthodontic appliances, we've done some soft tissue work, provisionals, and we can see that over time, and looking at the case, we've taken the case through from a starting point in 1994 to an end point in 1996 after some 18 months or so, which has met our goals. And we can then really look at this type of interdisciplinary approach and understand whether it's really standing the test of time. And this is the important thing. And now we can look at the same patient now some 11 years later, and we can see that really pretty much everything is holding up quite well. However, on the right side of your screen, you can see that the patient's left side has had some changes. There have been some biologic changes in terms of loss of volume of tissues, some recession, and perhaps we have to understand that in 1994, of course, we didn't really understand why. But of course, today we have a better understanding of the behavior of the tissues around our implant restorations and why they would perhaps behave this way, and certainly strategies that we would employ in our treatment today would try and prevent and manage this kind of a problem. But if we look at this case and we see the radiographs now, we can see how, this is the kind of result we want to achieve. And in 11 years, we've just had to carry out one further endodontic treatment of the upper right second premolar. But other than that, everything is stable and healthy, and the patient is maintaining the mouth to a high level, and that's really working. And this really gives us a lot of confidence that our strategies and our foundation principles of treatment, if we work with a systematic approach and pay attention to detail, that we can achieve this kind of long-term stability and follow-up. So control and predictability are really the keys in these types of cases. Of course, when we think about our restorations, we really want to have some idea of what we want from an ideal restoration. Well, we want to have soft tissue integration. We want to achieve and maintain health. We want to have strength and durability. And we want to have materials that allow us to manage the aesthetics of the patients, to mimic the teeth and their hue, value and chroma, their surface characteristics, to be able to mask underlying discoloration, and yet to have that vital translucency. So today we're working with cases where, if we see, for example, this particular lady here with some rather inadequate and poor existing restorations, and we've had to manage this, and we take this patient through this treatment with our sort of protocols today, is really to try and optimize the soft tissue. You look at the thin biotype. We've had to carry out some plastic periodontal surgery, some augmentation to manage the teeth as well as the soft tissues, to place our implants in the appropriate positions, to manage the volume of bone and soft tissue in those areas. And we're working with materials which allow us to enhance the optical properties and manage the aesthetics better, particularly all ceramics in these areas, for both the structures that we're placing as restorative restorations, crowns and bridges and so on, and as well as the abutments. And we can take that sort of process through with an all-ceramic approach in these cases, not without some challenges, because as you see in this case, we have an endodontically treated tooth with a post-crown next to an implant, next to a vital tooth, next to another vital tooth, another implant, another endodontically treated tooth. And we have to be able to manage these materials effectively, that we can create the right optical effects. And this takes some skill from our technical support. But if we look at this patient again, some 6 years later, we can see that we've achieved a stable outcome, that soft tissues are very nicely stable, and we've got an effective control of the patient. And this is really the goal for these kind of treatments over time. It's not just whether it looks good on the day, but how does it stand up to the test of time. So control and predictability is not just about the materials that we use, of course. Of course, those play a part. And of course, the implant companies would have you think that it's all about what system that you use or what material that you use that will be the key to success or failure. Of course, that's not really the case. The case is really that we understand as clinicians how to manage the biologic factors, how to design our restorations and design the and treatment plan our cases appropriately to manage the biology, the function, and the aesthetics to the optimum level. So what are we dealing with in terms of implants in the aesthetic zone? Of course, we're thinking about bone, a key issue. We're thinking about soft tissues, and we have to manage those. And of course, we've got very important components that we have to play with. So, excuse me. The key thing is that we're dealing with bones, tissue, and components. And those components are the implant, the abutment, and the prosthetic contours to some extent. And that we have to understand that the components that we utilize play a role in terms of how the bone and soft tissue respond. And it's really an understanding of the biology and the biologic response to these components will help us plan our treatments better. Because what we don't want to achieve is a result like this. And this is a sad case because it's a patient, it's a young patient that came to my practice several years ago, 22 years old, and has a high lip line and had only recently, I think something like a year previous to this picture, had an implant to replace a maxillary incisor. And I'm sure that the dentist that treated her didn't intend for this to be the outcome of the treatment. But it's clear to me that he didn't really understand the biologic consequences of what he was doing. In other words, that the attention to detail and to managing the positioning of the implant correctly and paying attention to volume of tissues and understanding the way that bone and soft tissue will behave is clearly not being apparent. And this has led to this compromised outcome. And so if we really understand the importance and the way that our bodies respond to our treatments, we can really better manage the end outcome. And this is really the basis upon which implant dentistry today, in the state of the art, is performed. In other words, that we really try and anticipate what's going to happen with the bone and soft tissues to minimize the impact of that on the aesthetic and the long-term results. And this is what we'll focus on today. So let's look at some of the key factors in the management of implants in the aesthetic zone. And it's probably worth really taking note of these and jotting these things down and having them clear. Because what we're looking at, first of all, is that we need to have adequate stable bone volume and architecture. And the key word here is stable. Okay? It's bone volume and architecture, but stable volume. We need to have the correct three-dimensional positioning of our implant, and that today is considered to be 3 millimeters apical and 2 millimeters palatal to the final gingival margin that you wish to achieve on the final restoration. In other words, the ideal gingival margin. We need to have adequate soft tissue thickness at the time of transmucosal connection, because we know that within any implant restoration, around that there is a peri-implant mucosal complex, which is described as a biologic width, but I think more accurately should be described as a biologic seal, which comprises of a sulcus, some junction epithelium, some connective tissue compartment to the level of the bone around the implant. And this biologic width, if you like, or our biologic seal, needs a certain dimension to create a seal between the epithelium and the bone. And of course, if we have that thickness of tissue already there at the time of transmucosal connection, whether it's your healing abutment or your abutment or your final abutment, whichever way you're doing it, it will minimize, in my opinion, it minimizes the amount of bone resorption that needs to occur in order to create sufficient thickness of tissue volume for this biologic seal. And it's one of the mistakes that we make. If we only have a millimeter of tissue and we need to uncover our implant, then the tissue has to create some remodeling of bone. The bone has to remodel to create that width of 3 millimeters or so to house this biologic seal. So this is an important thing to remember. The final abutment connection is also now timed. We try and place that a little earlier. If we're going to place it immediately, that's even better, but that's not always possible. But certainly early abutment connection and allow maturation of tissue to occur on that final abutment rather than on temporary provisionals. The transmucosal form, contours, and to some extent the material of the abutment and prosthesis are extremely important. We understand that the contours of our transmucosal components, having a narrow form, concave, narrow form, the smaller the components, the more the volume of tissue is what we're looking for today. And then, of course, we need to develop and maintain the correct, appropriate soft tissue contours. So these are 6 keys that we really focus on in implant dentistry in the aesthetic zone. And we'll focus on today some concepts with regard to the single tooth replacement, and hopefully later on to look at the multiple tooth replacement too. So let's look at some of the basic, what we know in terms of the biology. We understand that there's a biologic seal, described as a biologic width by a number of workers, and we know that this is influenced by the type of surface, whether it's smooth or textured, and whether we have a remodeling response which is influenced by disconnection and reconnection of components. Certainly in the data that we've seen, that perhaps this drives epithelialization to the level of the implant head, and then the connective tissue compartment has to form apical to this, which means that the bone must remodel to create space for this biologic seal. Hence my previous mentioning that if we can create adequate space of dimension of soft tissue before this, then we maybe reduce the need for apical remodeling of bone to occur. If we look at the literature, this has been translated, if you like, by a number of authors to mean that we see clinically some recession on the facial aspect of our implants, and this has been described as 1 to 1.5 millimeters in the first year after final restoration. And if you look at this very nice picture from my good friend Andre Sadoun, and it shows that he's seen me remodeling to the first thread on the implant, which is to establish this biologic seal, and this is the current concept and thinking today. And of course, if we look also at this picture, there are some clues as to some other problems that we might not be aware of. And if we look at the shape of the abutment, we see the very flared, broad, divergent shape of the abutment. This is contrary to how we would do things today. Because if we have wide components, then we have less space for soft tissue, less blood supply, less volume, and of course less stability. And we know that thin tissue is less stable than thick tissue. So I really want to question whether this is really true, that we see recession because this is normal, or is it because of how we manage the cases? Because I think one of the problems that we have with all the literature in implant dentistry particularly is the fact that it's very one-dimensional. It only looks at one aspect at a time, and of course we understand that really there are many different factors working together. The bone is important, the soft tissue is important, the quality and thickness of the soft tissue, the components that we use, the shape, the connection, the shape of the transmucosal aspects of these components, the host response, the individual patient may play a part. So all these things have a role to play, and we don't really know the best combination of these things. But we have to understand that just looking at one thing in a paper and saying, well, it's because of this or because of that, it's not necessarily the case. We also understand that the papilla in a single tooth implant is present because of is dependent on the bone on the adjacent teeth. There's a number of people that would confirm this, and we know that over time the papilla generally gets better. Torsten Jempt has shown that in his nice study that when they looked at patients with single tooth implants after 3 years, generally every classification of the papillae improved with time, so that the papilla will get better. So if we summarize what the literature tells us, it says papilla gets better and the facial gets worse. But more usefully, we go to looking at some more data on human patients from Joe Kahn and Loma Linda. Very nice, useful paper that showed us the peri-implant mucosal thickness around implant restorations that had been there. And they looked at some cases where the teeth had been there for 3 years in standard two-stage implant cases in the maxillary, in maxilla of humans with single teeth. And they were able to confirm really pretty much that the papilla is dependent on the bone on the adjacent tooth, not on the bone on the interproximal or the implant, but that there was a distance of some 3 to 4 millimeters between the gingival margin and the labial bone. Excuse me. And this was noticed to be different with people with different types of gingival biotype. They didn't really quantify what constitutes a thick or thin biotype, and as we know, this tends to be a rather subjective opinion anyway. It's difficult to evaluate, but certainly they saw that when we had thick tissue biotype or thick tissue, the distance between the gingival margin and bone was greater. In other words, there was less recession. The thinner the tissue, then the distance was shorter. In other words, there was a more tendency for recession to occur. And this really would make sense for what we are today. We of course see that the tooth form and the biotype are important. And square tooth form is much easier to manage than a ovoid or a triangular tooth form with tall scalloped gingiva. And we can see on the triangular tooth form on the right, we would have to probably cheat if we were to try and restore one of those maxillary central incisors, that perhaps we would have to add some contour to the adjacent teeth to create the contact point a little bit more apical, and in order to try and get a reasonable outcome. So it certainly creates a greater challenge for us. So let's look also at what we've learnt. Some of our experience in implant dentistry. Look at a case that we treated back in 1997, at the end of 97, you can see here, where we had the popularization of the immediate implant placement in the aesthetic zone and by people like Peter Worley. And we could see that we did an implant to replace this failing maxillary incisor, and the end result's pretty decent. Radiographically, everything looks fine. But when we look at that same patient some 6 years later, one of my own patients, of course, I can see that this is really a failure in that we've had remodeling and recession of the tissues, and we have to understand the reasoning why. And perhaps we can look at the picture and say that, well, okay, the form of the tooth is very convex. You can notice it's a convex form. This was what we thought was the appropriate shape of the contours of the transmucosal components. We used a very wide implant, and if we look at it close-up view, we can see that we made some fundamental mistakes that we wouldn't make today, but this is what we've learned. If we look, the implant is way too close to the buccal plate, and we know that that will remodel away, and we will lose some height. The implant is very broad, and this also compromises the contours of the transmucosal components, because they will also be very broad. We've raised the flap, which we wouldn't necessarily do today. This thin bone on the labial may not be adequate to resist the forces of occlusion, and the over-contour of the transmucosal components is obviously going to be an issue here. So, what do we do with a case like that? Well, what we do is we remove the crown and the abutment, we flatten the profile of the crown and the abutment. You can see in the abutment we create a slight concavity, and then we treat it like a recession defect. It's really very much like a recession, a Miller Class 1 recession defect. However, what's interesting, if you notice in this case, that the bone apically is only remodeled about 1.5 millimeters from the connection, about the distance of the connective tissue compartment in that biologic width. And we've lost volume on the facial. It's flattened, as you can see in the second picture on your screen. And so we really have to understand that the thing that we have to battle against is this flattening or this loss of volume, and this is what we need to manage. And in case we did a connective tissue graft and successfully restored the soft tissue profile, and you can see after some follow-up that we have a nice stable result, which is more appropriate and much better quality of tissue in that area. But this is going back, trying to fix something that we did wrong several years ago, that we didn't really understand the whys. One of the other issues that we see, as you can demonstrate with this case, that you see as we place an implant into this extraction socket, it looks like a very straightforward and easy patient to manage. We can see that one of the problems that we have is this labial loss of volume also creates a shadow or discoloration of the gingival tissues above the implant, and whilst the crown is pretty decent and the gingival architecture looks fine, this loss of volume on the labial aspect creates a compromised aesthetic outcome for our patients. When they smile at us, we can see a dark shadow above their teeth.